Hello friends, in this particular session we are going to talk about a topic from which you get a lot of updates, I would say almost every year. Any guess which is the topic? Yes, it is none other than TB, because we know that in TB you keep getting a lot of updates. Okay, so let's see what are the latest things in TB. And what I'm going to show you next is the new name of the program, which I'm sure you might be knowing by now, which is NTEP, National TB Elimination Program. Okay, and this is the logo of National TB Elimination Program. So let's see in just what are the latest things that have come in NTEP. Okay, we will discuss all of this in detail after some time, but just to give you a gist about, an overview or a bird's eye view of the things which are there in TB, I'm going to show you the next one. Did you know that in TB we have daily regimen now? Earlier it was alternate day regimen, now it is daily regimen. That means earlier it was like, every Monday, then Wednesday, Friday, or Tuesday, Thursday, Saturday. That is how the medicines were given. But now we have the daily regimen. And it is fixed dose combination. That means all drugs are combined into one single tablet. That means H, R, Z, E. All these are combined into one single tablet. You knew it, right? Okay. All these, see, the points that I'm going to show you as something new is not exactly the very new one, but it also includes the brand new points as well as relatively newer points. Okay. So you might be familiar with many of these. We have no treatment categories anymore. Earlier we were having, all new patients will go to category 1, all old patients will go to category 2, and we were giving them drugs accordingly. But now no category, because category was based on some assumption. If you feel that, okay, this patient is an old patient, you are assuming that he may not respond to the first line regimen, then under that impression that he may not respond, you are putting him on second line treatment. But now, no need of any assumption in NTEP. In NTEP, each and every patient is tested for all the available major anti-TB drugs, and they are given treatment according to their drug susceptibility. Okay. Then we have new drugs. Yes, this I'm going to highlight. These new drugs you can always expect as an MCQ. You might be familiar with Bedaquiline, Delamanid, because this is not very brand. I can't say this is not brand new, but the other one, Pretomanid, is something which was introduced very recently. Okay, so we have Bedaquiline, Delamanid, and Pretomanid that you have to keep in your mind as newer drugs that are there under NTEP. Then we have a new regimen. You might be familiar with all the other regimens. Now we have a new regimen which is BPaL-M regimen, which we will discuss after some time, okay, in detail. And we have no injectables anymore in the first line or second line or third line. The program is National TB Elimination Program. That means we are trying to eliminate TB, right? So if your intention is elimination, then it's better to avoid all the injectables from the treatment regimen, because, we all know that the patient compliance will be less if you are adding injectables. Nobody likes to take injections, right? So now the program says, as far as possible, no injectables at all. Earlier it was like, HRZES. Streptomycin used to be in first line, but now they say that as far as possible, no injectables at all. If every oral drug fails, then only you think about giving injectables. That is the new guideline. No injectables as far as possible. Okay. Then we have newer technologies like 99 dots, Nikshay, Aushadhi. All these we can discuss after some time. Okay. Then Nikshay Poshan Yojana. There is something new. Nikshay Poshan Yojana is not new, but there is something new which came in 2024. Towards the end of 2024 under Nikshay Poshan Yojana, which we will again discuss. Then we have active TB case finding. Okay, earlier it was like, only passive TB case finding. That means if any patient is coming to your hospital, you will diagnose the patient as a TB patient. But now we have active TB case finding. That means the field workers will go into the field actively searching for TB. Okay, and then we have Intensified TB case finding. Now, what do you mean by intensified TB case finding? That means you are intensifying the TB case finding in other clinical settings as well. Other clinical settings as well. Like if a patient is coming to ICTC, that is, this is the place, Integrated Counseling and Testing Center is the place where you are screening for HIV, right? And we know that TB and HIV always coexist, right? So, if someone is found to be positive for HIV, then you have to screen for TB as well, because we know that they are very good friends, and TB is the most common opportunistic infection in HIV, right? So, you are using that opportunity to screen for TB because they might also be having TB. Okay, so we have an HIV-TB collaboration. So, this clinical setting you are trying to, or you are using for diagnosing TB. Any other clinical setting, we know that TB and HIV coexist because HIV is an immunocompromised condition, and that is why they are getting TB. Is there any other immunocompromised condition which is very prevalent in India, and there also TB can coexist? I said very prevalent in India. It's a lifestyle disease. Yes, you are thinking it right. Diabetes mellitus. Okay, so in NCD clinic, especially if the patient is having diabetes, a case of chronic diabetes, then you have to screen for TB. Any other condition? In post-COVID clinics. Okay, in post-COVID clinics, you might have heard about something known as long COVID. That means after COVID, few patients might have some long-term signs and symptoms disturbing them. Mostly it will be in the form of cough. So you call it as post-COVID, and we have post-COVID clinics in India, in government center. So, if a patient is coming to a post-COVID clinic with cough, it could even be TB, right? So, there also you are screening for TB. So, this is intensified TB case finding. Okay. Then we have the next one, latent TB case finding. You know what latent TB is. Latent TB means TB bacilli will be dormant, and you are trying to find out even the dormant TB bacilli from certain group of people, which we will discuss after some time about the IGRA, and which is a specimen that you take, and what are the advantages of IGRA, and those things we will discuss after some time. Just for the time being, I am writing that MCQ. IGRA is a test that you do in latent TB, in blood. Then we have new TB preventive therapy, which again we will discuss after some time. Okay, you might be familiar with IPT, that is isoniazid preventive therapy, right? But now it is TPT, TB preventive therapy, because we are not only giving isoniazid, but we have some other new regimens as well. So what I want to tell you is the things that we are going to discuss, okay, along with few more other important points that you have to remember from TB for your exam. Okay. So let's start with when to suspect TB. Let's go in the correct order. When to suspect TB? You call it as Presumptive TB Criteria. That is the first MCQ. What are the Presumptive TB Criteria? That means when do you suspect TB in a person? You all will agree with me that it is cough. For how long? That is the first MCQ. Cough lasting for more than 2 weeks. Is that it? No, it's not just cough. Earlier it used to be just cough, but now we know that if you simply look into one symptom, you may miss a lot of other TB cases, right? So, to diagnose as many TB cases as possible, now we have expanded the Presumptive TB criteria, and along with cough, all those signs and symptoms pertaining to TB, if you find in a patient, you have to suspect TB. Like fever more than 2 weeks, could be TB, right? So this 2 weeks is very important, because earlier it was 3 weeks, now it has reduced to 2 weeks, okay? Then significant weight loss again, suspect TB. Hemoptysis, could be TB. Any abnormalities in chest X-ray, again, could be TB. So these are the Presumptive TB criteria, which is an MCQ. Which among the following is not a Presumptive TB criteria you can expect, and it is already there in the question paper, previous year exam question papers. Okay. Next, suppose a patient with so signs and symptoms have come to you. You have to diagnose, right? Which is the specimen that you take for diagnosis? It is sputum, no doubt about it, right? And how many sputum samples? 2 sputum samples. And you ask the patient to give sputum in a sputum cup. So I'm showing you, this is the picture of a sputum cup. This is a sputum cup. It will be kind of transparent and it will be screw tight. Okay. And which all 2 sputum samples? You said, or we have discussed that it is 2 sputum samples, right? So which all 2? One is spot sample and the next is early morning sputum sample. Spot sample means when you see the patient for the first time, you give a sputum cup and ask the patient to take sputum or collect sputum inside. Then you give one more sputum cup and you have to ask the patient to come back the next day with early morning sputum sample. Now I have a question, guys. Why are you insisting the patient to come with early morning sputum sample? What is the rationale of asking for early morning sputum sample? There has to be some reason, right? What is it? See, at night, when you're sleeping, your cough reflexes are usually suppressed. You know that, right? So there will be overnight accumulation of sputum in the trachea. Okay, and your early morning sputum sample will be studded or will be having a high concentration of TB bacilli. Now, the problem with sputum sample is by the time you reach hospital, you would have spitted all around, right? Or the patient would have spitted all around and only little TB bacilli will be left. That too, he had taken breakfast in the morning that will be contaminated with food particles. If he's a smoker, that will contain tobacco starch. So the problem is only less bacilli will be present and that too will be contaminated. So you are likely to miss a diagnosis of TB if you just go by spot sample. Whereas your early morning sputum sample will give you a high yield. Are you with me? Okay. So you ask the patient to give 2 sputum samples. What next? You have to do the test. Which is the test? If you are saying AFB, that is wrong. It's not AFB anymore. It is NAT. Okay. It is NAT. Don't say CBNAAT because in the latest guideline, it is written as NAT because we have 2 types of NAT. One is CBNAAT and the other is TrueNat. Now, what is CBNAAT? Cartridge-based nucleic acid amplification test or GeneXpert. I'm going to show you the picture of CBNAAT. What you see here is the CBNAAT. It's an American company that is producing. GeneXpert is an American company that is... or it is produced by an American company. It's quite expensive. And in India, we have a new made in India NAT, which is TrueNat. At least after the COVID pandemic, you might have heard about this TrueNat because for diagnosing COVID, we were mainly using TrueNat. As you can see in the picture, it's a small portable device which you can carry up to the point of care. Okay, this is TrueNat. So you can expect both as an image-based question. And cartridge-based nucleic acid amplification test, as you can guess, here you are using a cartridge. I'll show you the picture. As you see in this picture, there is a cartridge in which you can take 2 ml of liquid sputum and then you have to put it inside the box or inside the machine and you will get result in 1 hour 45 minutes. That means in less than 2 hours, you will get the result. And it will be displayed in the monitor as you see here. And this is TrueNat, okay, which is an Indian company or which is an made in India product. Okay. Anyway, the point that I want to put across is it is not AFB. As per the guideline, each and every presumptive patient should undergo NAT. So if you're getting a question, which is the test, it is NAT. Okay. So my question is, why NAT? And not AFB. Why are we insisting that every patient should undergo NAT? That means there are some advantages for NAT. First is, we know that for sputum microscopy to be positive, you have learned that per ml minimum there should be 10,000 bacilli, right? Whereas NAT is nucleic acid amplification test. So it can detect even if there are only 100 TB bacilli. That means even less bacilli will be detected by NAT. But same can be done with culture as well, right? But why are you insisting for NAT? Culture will take a long time, whereas NAT will give you prompt result within 2 hours, right? And there is one more advantage for NAT. What is it? This will also tell you whether the patient is sensitive or resistant to one of the most important anti-TB drug, which is rifampicin. So, rifampicin resistance, which is the resistance that is given by NAT, is a very commonly asked MCQ. Okay, so it will tell you whether the patient is having any mutation in the gene, which is corresponding to rifampicin resistance. Okay, RIF gene. Okay, next, moving further, there are a few more new things in NTEP. Do you know we have two new terminologies added under NTEP? One is loss to follow up and the second is recurrent TB. Then you might be wondering, what were the old terms? This looks like, oh, something which you can understand. But the thing is, there were some old names. And this has already come in an MCQ 1 year back. Which of the following is not a new term? Okay, so let's see what is loss to follow up. Old name was defaulter. Okay, and who is a defaulter? Defaulter is a person who has started on TB treatment and he's leaving treatment for more than, next MCQ, whatever I write is an MCQ, okay, more than 4 weeks. Okay, so that is a defaulter. The new name is loss to follow up. Now you might be wondering why new term? What is the implication? Defaulter means, you're putting the blame on the patient, right? He defaulted. You will say that, okay, my patient defaulted. Whereas loss to follow up, what is the implication? I, as a doctor, lost my patient to follow up. So it is my responsibility to see that my patient will complete TB treatment. Are you understanding, guys? Okay, so now the program says it is your responsibility to see that the patient will complete the treatment. So the name also changed accordingly, loss to follow up. Okay, next is recurrent TB. Old name was relapse. Old name was relapse. Okay, now what is the case of relapse? You know it. This is something that we always use, right? Relapse means a patient who was sputum positive and then he was converted at the end of the treatment to a sputum negative case, but after that he's again coming back with sputum positive. Okay, so a patient who got disease once again after completing the treatment is relapse, but the new name is recurrent TB. Recurrent TB. Okay, so this is the next name. So these two are new terminologies which are there in TB treatment. And in the last year exam, the answer which was there, the question was, which among the following are the newer terminologies except was failure. Now, what is a case of failure? Failure means a person who was found to be positive at the end of sputum positive at the end of most recent treatment. Okay, a person who was found to be positive at the end of most recent treatment. So after taking treatment, during the time of treatment, if the patient is found to be positive for TB bacilli in the sputum, then it is a case of failure. Failure, old name was failure, new name is also failure. Okay, so these are the things that you have to keep in your mind. Moving further, few more terminologies. They are not new, but something that you have to understand for the exam. One is drug-sensitive TB. Don't you know that nowadays we are classifying the TB patients into a patient who is drug-sensitive and drug-resistant TB. Okay, so drug-sensitive TB means a patient who is sensitive to all first-line anti-TB drugs. Now, what is mono-drug resistance? Mono drug means, as you can guess, I think I don't have to tell you. What is mono? Mono means a person who is resistant to any one anti-TB drug, especially to rifampicin. It could be a case of rifampicin resistant or it could be a case of INH resistance. These are the ones commonly seen. Okay, then if you have multi. Now, what do you mean by multi? Means more than one. And it's not just any more than one, but there has to be a combination which is INH plus rifampicin. That means a person who is resistant to both INH and rifampicin, you call as a case of MDR-TB. Then you may ask me, what if there is resistance to more than one drug, but you won't find this combination of INH and rifampicin? Is there any terminology given for that? Yes, that is polydrug resistance. Okay, that means more than one, but this combination of INH and rifampicin will not be there. Once you see this combination, that naturally becomes MDR-TB. Okay, so these are again another set of MCQs which you have to keep in your mind. Okay, then Anything else beyond MDR? We know it is XDR, right? And what is XDR? XDR is extensively drug resistant TB. Okay, extensive means MDR plus extra, right? It is MDR, that means INH plus rifampicin plus some extra is XDR, right? And whenever I ask students, they say, Madam, it is MDR plus fluoroquinolone, any one fluoroquinolone plus any one second line injectable. This is the answer that I always get. It used to be like that. Okay, but not anymore. There is a small change. Do you remember in the first part, I had shown you some new updates and I said we are not using injectables anymore. That means even second line injectables are not there. By the way, guys, I hope you know which were the injectables we have. Remember the injectables we have, or we still have, but we are not using it that much, are, you can remember this mnemonic, SACK, SAC. What is S? S is streptomycin. With A, we have amikacin. With C, we have capreomycin. And with K, we have kanamycin. If you're getting a question, which are the injectables available? The major injectables, you can remember using this mnemonic SAC. Now, what I'm trying to tell you is, we are not using injectables in second line, right? So, you can't use this anymore. That means, now you are just left with MDR plus fluoroquinolone, right? Is that XDR? No, that is not XDR, but this is given a new name, which is something which is coming before XDR, which is, look at the new name, Pre-XDR. Are you seeing? Something which is before XDR, which is Pre-XDR. So it is MDR or rifampicin resistance, which is the most important one that you get in the first test itself, right? So MDR or rifampicin resistance plus fluoroquinolone is known as Pre-XDR. So Pre-XDR is MDR or rifampicin resistance plus any one fluoroquinolone resistance is Pre-XDR. From pre, you move on to XDR, right? So the next question is, what is XDR then? So pre, that means MDR plus rifampicin resistance plus something else will become XDR, right? And what is that something else? If the patient is, along with pre-XDR, if the patient is also developing resistance to any one of the other group A anti-TB drugs, okay, group A anti-TB drugs, then you call it as XDR. Are you with me? Now, your question would be, what are these group A anti-TB drugs? Don't worry, I'll show you the latest anti-TB drug table. It's a new classification. And you will see that in the new classification, we have group A, B, C and other medications. And in group A, can you see, there are only 3 types of drugs. One is fluoroquinolone, which include levofloxacin or moxifloxacin. Then we have Bedaquiline and then linezolid. Okay, so if the patient is developing resistance to any one of this, that becomes pre-XDR. Along with that, if the patient is also developing resistance to either Bedaquiline or linezolid or both, that becomes XDR. Am I clear? And nobody will ask you which are the drugs you have in B, C and D. You don't have to bother. I just wanted to show you this is the new classification of anti-TB drug. And what you need to remember is, WHO say as far as possible, you try to use drugs in A, B and maximum C. Try to avoid the drugs in which are kept at the bottom of the table, because you know, as you move down, the side effects as well as the complications because of these drugs will increase. Okay, so as far as possible, stick on with A, which we know it's not always possible. Then you can think about B, then you can also think about C. That means, you know, Always try to include the drugs which are there in the upper classes. Okay, so that is XDR, resistant to at least one. This is the definition that I have said, resistant to at least one additional anti-TB drug, and group A, these are the ones. I hope it is clear.